I'm sorry, I'll stop the dog from. Hold on. Let me just put it on the internet, put it on my website. Now I'm putting it on Neurosurgical TV on the front page. So when people go to it, there it is. And I'm gonna basically put some code there, which you guys don't have to know, really. Okay, live stream. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, sunny Miami Beach. I'm glad to say we have the honor of having Georgios Matis, a neurosurgeon originally from Greece, now practicing in Germany, specialized in pain management. This was arranged by Abdul. Let me have him say hello. Abdul, can you just say a quick hi before I introduce Georgios? Abdul, are you there? Perhaps he stepped away. Oh, go ahead. Hello, yeah. Abdul. He's a chairman of the Walter Dandy in Sudan.
Yeah, hello, Dr. Georges.
Hi. Hello.
Okay, Georgios, thank you very much, and it's all yours.
Thank you very much for the introduction. Thank you very much for the invitation. Let me share my screen with sound. Please let me know if you can see my presentation.
Yes.
All right, so let's start. My conflicts of interest, although I don't think it's really relevant. I'm consultant for these companies, the agenda. I would like to speak about neuromodulation. What is neuromodulation? How neuromodulation can help patients with chronic pain, and some things about social media and neuromodulation. So let's start with the basics. What is neuromodulation? When I first started working in this field, I didn't really know what it is. So I went and visited the official website of the International Neuromodulation Society, and there you can find this definition: the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. There are many diseases that can be treated using neuromodulation. What's important for today's webinar is the pain. A big list with possible operations. All these things are neuromodulation, and I have not written down everything. I will try to cover some of them today. So let's start with chronic pain. Chronic pain, of course, is not a new problem. People always had pain, and these are some German magazines, the very famous ones, and we can always read articles about pain, acute pain, chronic pain, and many readers are really interested in these topics, not only physicians. What do we see in everyday life? Which patients are coming to us? We have patients with trigeminal neuralgia or neuropathy, or a combination of them, and different types of headaches, cluster headache, for example. We have patients with back pain, neck pain, arm pain, leg pain after a surgery in the spinal column. We have patients after amputations with phantom pain or stump pain, with polyneuropathies. Imagine a patient with diabetes mellitus, or after chemotherapy, tumor patients, plexus lesions, angina pectoris, patients who have already been treated with stents, with bypasses, with drugs, but they are not satisfied. They still have chronic pain. Patients with peripheral vascular disease, patients with postherpetic neuralgia, patients with complex regional pain syndrome with or without capsalgia, and tumor pain. Interventional pain therapy. We can act at the level of the first neuron. Here we have the dorsal root ganglion stimulation or pulse radiofrequency. We have the peripheral nerve stimulation or the peripheral nerve field stimulation, actually the implantation of leads under the skin. We can act at the level of the second neuron. We have the spinal cord stimulation, which is a big part of this talk today. The intrathecal therapy with or without opioids. Zeconotide is an alternative drug, which is FDA approved. And at the level of the third neuron, we have motor cortex stimulation and deep brain stimulation. I think most of you know the World Health Organization ladder. We should start with non-opioids, then move on to weak opioids, then end up to strong opioids, and in the end, we have the intrathecal therapy with or without opioids. What we have seen is that if we start with our neuromodulation options, for example, the peripheral nerve field stimulation or pulse radiofrequency or spinal cord stimulation, before even trying to give our patients the opioids, then the clinical results are much better. And this is not what I am saying. There are publications on this topic. A really important one, according to my opinion, is this article coming from Dr. Slavin and Dr. Maguire. They are writing about a paradigm shift towards a surgical management of the chronic pain. And this could have implications not only for the patient and their families, but also for the whole society. So let's take it step by step. Let's move on to the first neuron. What type of therapies do we have there? We have the stimulation of the dorsal root ganglion or DRG, when the pain is good localized in the foot area, in the knee area, or in the groin area. Here we have to implant 1 till 4 leads under the pedicle.
To the brain.
This is
The DRG has emerged as an exciting new target for spinal cord stimulation. Measuring several millimeters in length and containing thousands of cell bodies, it provides a compact focal structure that can be accessed using epidural techniques. Sensory and motor inputs diverge at the DRG, making it a convenient target for neuromodulation. In chronic pain states, cell bodies in the DRG become hyperexcitable, causing neurons to fire abnormally. Research has shown that electrical stimulation of the DRG can decrease cell excitability and modulate the sensation of pain. The ganglia are organized around spinal nerves that map to sensory dermatomes. This feature allows therapy to be targeted to specific pain areas in the body. At the same time, overlapping innervation patterns also enable broad coverage. Unlike the dorsal column, the DRG is surrounded by minimal cerebrospinal fluid, or CSF. CSF acts as an energy sink and can unintentionally distribute current to other neural structures, causing unwanted stimulation or motor activation. With dorsal column stimulation, body movement such as lying down or standing up may result in uncomfortable stimulation. This happens because the depth of CSF varies with positional changes, causing fluctuations in stimulation intensity. Since there is minimal CSF around the DRG, stimulation intensity remains consistent even with changes in body position.
So this is an old video from a company that's not exist anymore, but you have to excuse me, all the good animations are made from big companies. So this is not an advertisement for a specific company. I just thought it was really interesting and helpful for the people who are watching this webinar. Pulse radiofrequency. This is a high-frequency therapy. We are stimulating for 20 milliseconds, then we stop for 480 milliseconds. The frequency is really high, 500 kilohertz. You can see an example of a generator we're using to provide the energy, an example of a catheter we're using in the epidural space. And here you can see with yellow the conus medullaris and with red the roots. How do we place the catheter in order to stimulate these roots? We can place the catheter in this way, or in this way, or in this way. It depends on the roots we want to stimulate. If we want to stimulate the sacral roots, we have to implant the catheter in the midline because this is where the sacral roots are. If we want to stimulate the thoracic roots or the lumbar roots, then we have to place our catheter in the lateral space. We have also this continuous radiofrequency lesioning or ablation, radiofrequency ablation. This is a destructive measure. Here we apply heat to the nerves, which conduct the nociceptive stimuli, and the best examples are facets and the sacroiliac joint. Here we can apply temperature of 60 to 90 degrees for 2 minutes or 90 seconds, and with this heat, we try to destroy the nerves. We don't stimulate anything with this therapy, we destroy. And these are some needles we could use in order to do this ablation in the area of the facets or in the area of the sacroiliac joint. Another alternative is a special instrument from a specific company for the sacroiliac joint. With this instrument, we can cover a bigger area and destroy much more small nerves in this sacroiliac joint area. This is what we see in the operating room, how we see the needles, the generator, and the C-arm, the fluoroscopic device. One important indication for neuromodulation is trigeminal neuralgia, when the patients are having pain attacks in the face. As a therapy, we have the fractional thermocoagulation. The principle here is that we apply heat and we destroy the C fibers, which are less well myelinated than other fibers, meaning they are more sensitive to heat. And under fluoroscopic control and sedation, we do a puncture via the foramen ovale. We have two orientation points, the pupil and a line between the external auditory canals. We are testing with 2 Hz. We should see that the jaw is moving rhythmically. We stimulate with 75 Hz. The patient should have a tingling sensation in the face, and then we apply a high temperature of 60, 70, or 90 degrees for 6 minutes in total. This is what we see in the operating room. Anterior-posterior and lateral view, you see the direction of the needle and the tip of the needle, and the motor testing of trigeminal nerve. You see the jaw is moving. This is stimulation with 2 Hz. PNFS, peripheral nerve field stimulation, implantation of leads under the skin, where exactly 9 to 10 millimeters under the epidermis, but this of course depends on the anatomy of the patient, on the fatty tissue of the patient. And why is that? Because if we implant the lead too superficially, we cannot stimulate anything. If we implant the lead too deep, then we have additional pain. We have a contraction of the muscles. And this is an animation coming from a specific company showing the concept of this therapy. We do a puncture through the skin, and through the needle is coming the lead, which stays in the vicinity of nerves and blood vessels. Then we remove the needle, the lead stays there, we fixate the lead with sutures, and we're doing a trial, a testing, which is the target. Well, when I finished the medical school, actually, I didn't know that we have these cluneal nerves. So these are the target here, the superior and inferior cluneal nerves in the back area. And you see a possible implantation of the leads on the right side of the screen. There are many examples. We can implant such leads parallel to the lumbar spine or perpendicular to it, an intraoperative image in the middle with 2 leads. We're going through the skin. This is the maximum we can do, 4 leads. Why this is the maximum? Because the IPG, the neurostimulator, the battery, has only 4 ports. This is the maximum amount of ports we can have. When I first saw this thing in a patient with failed back surgery syndrome, or the new term persistent spinal pain syndrome, I thought of that, looked similar. And we have many other indications for this therapy. These are very old cases and X-rays. This is actually the history of neuromodulation. You see on the left side a lead with 4 contacts. Now we have leads with 8 contacts. One potential indication is genitofemoral neuralgia. We have also ulnar neuralgia. You see 2 leads with 4 contacts there in the elbow area, stimulating the ulnar nerve. We have patients with CRPS, complex regional pain syndrome, and for example, ankle pain. You see 2 leads with 8 contacts in the area of the ankle, and the IPG, the neurostimulator, is implanted in the leg area. Of course, we have scars in order to implant these leads, but with a little bit of imagination, we can make the best of these scars. We can have a little bit of fantasy. This is an example of a patient who likes cycling. He had an accident. You can see the scar, and the black arrows show the direction of two leads. We had implanted two leads under the skin parallel to this scar, and you can see where we implanted back then the IPG, the battery. The patient came many years later back because the battery was empty and we had to replace the neurostimulator. Please keep in mind this patient. We're going to speak about him a little bit later. Neuropathic face pain, patients that are coming to us with a permanent pain in the face, and most of them are describing this pain as fire. This is a patient with pain in the second branch and the distribution of the second branch of the trigeminal nerve. This is also a very old case, a lead with 4 conducts. This is the trial. How do we do the trial? We plant a lead through the skin. This is the second branch of trigeminal. We fixate the lead. The patient is going home. After 1 week, comes back. We remove the lead. We speak with the patient. And if the patient is satisfied, we can implant a new lead, a permanent lead, after some weeks. This video comes from Dr. Russell from the United States, showing the implantation of supraorbital nerves. This is a very good therapy for patients with chronic headaches of different types. It's really very helpful. You can see it looks a little bit brutal, but the patient is sleeping, does not have any pain. We have to implant these leads under the skin. We have to fixate them, then bring them behind the ear, and then bring them in front where the clavicle is if we want to implant the IPG there, or in some cases in the buttock area. And this is a patient with atypical trigeminal neuralgia. It's in German, but even if you don't know German, please have a look at her face.
Der Schmerzschrittmacher funktioniert perfekt, also besser kann es gar nicht laufen. Und ja, ich wollte mich einfach bei meinen Ärzten bedanken, dass sie mir das ermöglicht haben. Und ich wünsche allen, die immer noch unter den Schmerzen so leiden, wünsche ich, dass sie auch diese Erfahrung machen und schmerzfrei in den Schnee können und überhaupt schmerzfrei das Leben genießen können. Ich habe zwar noch einen weiten Weg vor mir, weil ich Schwierigkeiten habe mit dem Absetzen der Medikamente, aber das schaffe ich auch noch. Ja, und allen ein frohes neues Jahr und ja, ich wollte mein Glück einfach mit euch teilen und mich bei meinen Ärzten für dieses Geschenk bedanken.
So, this young lady is married with children. She's a nurse, actually, and she says here in this video that for the very first time after many years, she was able to go out and enjoy the snow, because usually these patients cannot tolerate the cold weather. When it's cold, they have even more pain. So after the implantation of the subcutaneous leads, and you can see here the X-ray of this patient, she has also a lead in the occipital area in order to stimulate the occipital nerve. So on the X-ray, it looks a little bit strange, but in everyday life, it is possible to do that, and the patients don't have any problems. Actually, they are enjoying their lives. This is another case. This is a combination of 2 therapies. The red arrow shows 2 leads, subcutaneous leads, and the blue arrow shows the tip of a needle. So here we combine the peripheral nerve field stimulation and the fractionated thermocoagulation. Why? Because the patient has permanent pain. This is why we implant the leads. But on top of that, he has some attacks, like electricity. In order to treat these attacks, we have to provide another therapy. This is the fractionated thermocoagulation. Another patient with 2 leads with 4 contacts with postherpetic neuralgia in the first branch of trigeminal nerve. This is also the history of neuromodulation. This was the first patient treated in my hospital many years ago. We implanted a lead in order to stimulate the occipital nerve. And you see here also a second lead in the cervical area because the patient had also cervical pain. Please keep in mind, this is a very old case, many years ago, back then the results with spinal cord stimulation were not so good. This is why back then the colleagues made many, many more implantations of subcutaneous leads. Other indications, patients with knee pain, patients with phantom pain, patients with stump pain, and we have also this option of wireless PNFS, peripheral nerve field stimulation. Here we implant a lead or two leads with 4 or with 8 contacts, and we don't have a battery, meaning that each time that the patient wants to stimulate the nerve, should wear this antenna over the lead. So the concept is nice, but sometimes it's not very practical. Imagine you're in Greece in summer with 40 degrees temperature, and you have to wear all these things over the lid. But this is also an option in specific patients. Peripheral nerve stimulation, here we implant leads exactly there where the nerves are, not in the vicinity of the nerves, but exactly there where the nerves are. The advantage is that we need much less electricity, much less electrical signals. Another therapy, pretty new, is the stimulation of the multifidus muscle. Multifidus muscle is the main muscle that stabilizes our back. Here we can implant 2 leads in order to stimulate the medial branch of the dorsal ramus at the L3 level. You see these leads, how they are making a V sign, and they are both connected into a IPG. We don't have to do a trial for this therapy. We implant the leads and the IPG during one surgery, and then the patient has to activate the system twice per day for 20 or 30 minutes. And the goal is that after 2 or 3 years, we can explant the system, because within these 2 or 3 years, we can rehabilitate the muscle, and the patients actually don't need the system anymore. And this is an animation showing how this works.
Designed to electrically stimulate nerves to activate key stabilizing muscles of the lumbar spine. Chronic low back pain consists of an ongoing cycle of muscle weakening, pain, and activation suppression of the core spine muscles by the brain. Reactivate is designed to stimulate the nerves responsible for contracting the multifidus muscles. The brain senses the muscle contractions, and in response can trigger restoration of muscle control. With the multifidus again providing joint stability, the continuing cycle is interrupted, facilitating a recovery from chronic low back pain.
Hopefully it's not boring for you. Let's move on to the second neuron. Here we have the spinal cord stimulation therapy and the intrathecal therapy with or without opioids. Everything started with this publication in Science, 1965, the famous gate control theory, which actually states that if we stimulate the big diameter fibers, then we can block the transmission of pain signals to the brain. 1967, PNS, peripheral nerve stimulation. These two colleagues, Wall and Sweet, actually made experiments on their own face. They stimulate their own nerves to see if it is working with subcutaneous nerves, and it worked out. And in the same year, 1967, the first clinical application in a patient with a lung cancer. The daughter of the patient was an anesthesiology nurse and persuaded her father to undergo this surgery. The patient accepted and did have a substantial pain relief, but died 6 days after the surgery because of endocarditis. But he was satisfied with the therapy. What do we stimulate with this therapy, with spinal cord stimulation? According to many publications, we don't really know what we stimulate exactly. This, of course, depends on the type of stimulation, on the waveform, on the stimulation paradigm. We could stimulate the dorsal columns, we could stimulate the dorsal horns, we could stimulate actually both of them. And how it works, there are some segmental effects, meaning effects at the level of the spinal cord, but there are also some descending inhibitory pathways. Here, the concept is that we plant 1 or 2 leads epidurally, we stimulate for some days, and if the patient is satisfied, we connect the leads to the permanent battery, to the permanent neurostimulator. And this is an animation from another company showing the difference between the tonic stimulation, the gold standard, the high-frequency stimulation, the sub-perception stimulation without any tingling sensation.
Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. HF10 therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kHz. The result is greater neural inhibition and thus greater efficacy.
So this is the mechanism of action. This is what we see after the surgery or during the surgery. We can implant one lead with 8 contacts, 2 leads with 8 contacts, one lead with 16 contacts, or 2 leads with 16 contacts. Everything is possible. This is what we don't want to see. This is a patient that came to us from another hospital. We did an X-ray and we saw this thing here. The lead is actually subcutaneously placed and not epidurally. And this is how a whole system looks like. You see the lead, you see the white thing is the anchor, and you see the battery. You see also some types of connectors. On the upper right part is a more simple connector. On the lower right part is a more complicated connector for older leads from a specific company. So nowadays we have many options. And we have also guidelines, because we need guidelines. Our guidelines in Germany are not so new. We have them since 2013. Hopefully this year we have the new version of them. Many associations are involved, the cardiologists, neurosurgeons. We are performing the neuromodulation procedures, neurologists, and many more. And we have some inclusion criteria. Actually, patients could try everything: drugs, physiotherapy, cognitive therapy, psychological support, and nevertheless they still have pain. Exclusion criteria, and these are even more important: severe coagulopathies, mental disturbances, addiction problems, secondary gains, if the patient don't want to go to work, for example, the inability to use the system, advanced malignant tumor, and of course infections in the area of implantation. According to our guidelines, the best 2 indications for this therapy is CRPS without capsalgia and failed back surgery syndrome or persistent spinal pain syndrome. For other indications like angina pectoris or peripheral vascular disease, the indication is open. Open means we could try it, but it is not recommended. A very interesting publication in the European Journal of Pain from many colleagues from all over Europe, mainly anesthesiologists, and based on this publication, a company constructed this website, this eHealth tool. It's for free. You can register there. You can give the clinical data of your patient, the psychological data of your patient, and the tool will provide a recommendation if the patient is a good candidate for spinal cord stimulation or not a good candidate, or if the patient is in a gray zone. This tool was developed because we wanted to help many general practitioners to know which patients could be candidates in order to refer these patients to us. The majority of patients who are coming to us for spinal cord stimulation are patients with failed back surgery syndrome. And we know, according to publications, that the failure rate of lumbar spine surgery is somewhere between 10 and 46%. So this is a high percentage. And we also know that if we keep operating these patients, then the patients are not really satisfied. And this is why we had different algorithms how to treat these patients with back and leg pain. And back then it was really important to know if the patient has only leg pain or only back pain or both of them. And if they had back pain, was it local or diffuse? And accordingly, we could start with peripheral nerve field stimulation or with spinal cord stimulation with 1 kilohertz as frequency or 10 kilohertz as frequency. We could combine 1 or 2 leads. We can use another type of stimulation, the burst stimulation, which is also subperception. But nowadays, because the results, the clinical outcomes of spinal cord stimulation are really, really good, we have almost abandoned this peripheral nerve field stimulation therapy. Okay, and this is one more waveform that we can apply, the burst or burst ER. Here we have packets of high frequency pulses. The patient does not feel any tingling, but the pain relief is there. And why is it important? Because we know that we have two pain pathways, a lateral one and a medial one. The lateral is responsible for the perception of pain. The medial pathway is responsible for the affective components of pain, how we react emotionally to the pain, how much attention we pay to the pain stimuli. And we know now that the tonic stimulation affects the lateral pathway only, but the burst stimulation affects the lateral and the medial pathway as well. This is why the clinical results are better with the stimulation. A new technology is this frequency pairing from a specific company. Here we can combine the tonic or burst stimulation with a frequency, with a high frequency, but the word combine is not really correct because these waveforms are not running at the same time. We stimulate with a tonic stimulation, let's say, then with high frequency, then again with tonic stimulation, or the same with burst, but not at the same time. With another company, we have the possibility to actually combine the waveforms, and we can combine two different waveforms for the same pain area, or we can use waveform A, for example, for back pain, waveform B for leg pain. And the hope is that if we keep changing these waveforms, then maybe we can avoid in the future the problem of loss of efficacy or habituation. The problem where the patients are coming back after some months or years, and although the system is working, the pain relief is not there. And this is what we see when we're doing the programming. This is a lead with 16 codecs. We can save different programs in the IPG with different frequencies, pulse widths, and many, many other parameters. We have really many options. And why is this important? Because we know, and this was presented at NANS in 2015, so 8 years ago, that different types of stimulation activate different areas in the brain. You see on the left side a standard rate, so the tonic stimulation, the paresthesia, and on the right side, a stimulation with 1 kilohertz. This is a subperception stimulation. You see the areas which are activated are really different. A pretty new technology is this closed loop stimulation. The first publication in neuromodulation technology at the neural interface, the official journal of the International Neuromodulation Society coming from Australia. And this was the concept. Why closed loop? Because the lead can stimulate, but at the same time measure and capture these ECAPs, these evoked compound action potentials, compare the amplitude with a preset point, calculate a new stimulation current, generate new stimuli, and then once again capture the next ECAPs. And this picture shows the principle a little bit better. On the lower part of the picture, we have the classical, the typical, the open loop systems. The black line is the stimulation. What we would like to see is that this black line, the stimulation, always within the therapeutic window stays. And it shouldn't matter if the patient is studying or walking in place or sitting or coughing or doing something else. Why? Because if this line is over the therapeutic window, that means that the patient is getting much more electricity than he or she needs. If this black line is below the therapeutic window, that means that the patient does not get the amount of electricity, of electrical signals that he or she actually needs. On the upper part of the image, we have the closed loop systems. Here you see that almost always, 99% of the time, the stimulation, the black line, stays within this therapeutic window. It doesn't matter if the patient is studying or sitting or doing something else, meaning that the patient does not get an overstimulation or an understimulation. This is always the theory. An animation coming from the specific company showing this principle. The lead is stimulating. Because of the stimulation, we have this red line there, this ECAP. The lead can measure this ECAP and adjust the stimulation. So here we have actually a real-time measure of the response of the spinal cord to the stimulation. And this is what we see in the operating room. This is how ECAPs look like in everyday life. Another waveform from another company, differential target multiplex. With this one, we should stimulate at the same time neurons and glial cells. And why is this important? Because the glial cells are involved in many processes: neuroinflammation, amplification, modulation, and distortion of afferent sensory signals. And we also know that these cells outnumber neurons in the spinal cord, and the ratio is 12:1, meaning that they must be somehow important. This is how we should place the leads epidurally, the one lead at T8, the second one at T9. Here we have one basic program with 50 Hz and 3 prime programs with 300 Hz. For me, this is one of the best indications for spinal cord stimulation, although it's not included in our guidelines. Patients, once again, who already tried stents, bypasses, medications, and they still have pain. Here we can implant a lead with a tip at C7 or T1 on the left side, and we can stimulate the heart. If a heart attack comes, the patient will not sit, so spinal cord stimulation cannot cover any acute pain due to an infarct. And the second really good indication for me is the peripheral vascular disease, if it's possible stage 2B or 3, in some cases also 4. Here we implant a lead, if it is for the legs, with a tip at T10 in the middle line so that we can cover both legs at the same time. And please have a look at the right side of the screen. Control means that we don't stimulate. You see the color of the foot, it is green. 30 minutes after stimulation, you see the color is becoming completely different. It's red. Red means that more blood is coming in this area, so the perfusion is better. And when the perfusion is better, the pain is also less. If you are interested in the topic, this is a, I believe, nice review article published in the British Journal of Neurosurgery on peripheral vascular disease and spinal cord stimulation. We also have the possibility of the wireless spinal cord stimulation. We can implant a lead in the epidural space without a battery, but the same principle applies here. Each time the patient wants to stimulate, should wear, with the help of a belt, this wearable antenna over the lead. And this could be with several problems associated. Once again, the wearable antenna and the leads, which are actually receivers. We have also the possibility of a hybrid stimulation, the combination of spinal cord stimulation, you see a lead in the thoracic area, and peripheral nerve field stimulation. You see 2 leads subcutaneously where actually the screws are. Here we have 2 therapies that are running at the same time, and all 3 leads here are connected to the same battery, the same neuromodulator. Remember the patient with the leads under the skin. This patient, after many years, came back and told us, I have more pain now. We implanted a spinal cord stimulation lead, so epidurally. And now the patient has actually 2 IPGs, 2 batteries, and has 2 therapies that are running parallel. A subcutaneous, 2 subcutaneous lead for peripheral nerve stimulation and epidural lead for spinal cord stimulation. He's really happy, he keeps cycling. Spinal cord stimulation is not a new therapy. We have this therapy since more than 50 years now. And this is our history of neuromodulation in Germany, the first spinal cord stimulation meeting in Freiburg in 1974. And all these devices you can see here are actually receivers. There's no battery inside. And each time the patient wanted to stimulate, should place this antenna over the skin. The receiver was, of course, implanted under the skin. And each time they want to stimulate, they should place this antenna over the receiver. Some very old systems, this comes from Medtronic. This was the first company which worked in this field. You see a lead and very old IPG and the corresponding X-ray of this device. And for me, this is interesting because this is how back then the sales rep were doing the programming of these systems. They were moving around with such suitcases with this device in order to do the programming. Nowadays, we have iPads and everything is much, much easier. And we started, or the colleagues started back then with leads with only 1 contact. And now we have leads with 4, 8, 16, or 32 Kodaks. These are very old X-rays from different patients with subcutaneous or surgical leads. And here in the middle, you see actually a combination therapy of two different therapies. On the left side, you see a pump, intrathecal therapy. On the right side, you see an IPJ neurostimulator, spinal cord stimulation therapy. And this was many, many years ago. The first leads with 1 Kodak, 2 Kodaks, 4 contacts. And we're talking now about the future. What will the future bring? But in order to expect something from the future, we need something first. We need data. This is an editorial written in the Interventional Pain Medicine and Neuromodulation. If you're interested, you can read it. And this is a very interesting article. It's about FAST. This is the newest waveform that we have. Fast-acting subperception therapy comes from the United States with clinical results. At the level of the second neuron now, we have the intrathecal therapy, once again, with opioids or without opioids. Just to keep it short, this is, by the way, a very interesting article. I suggest that all colleagues who are interested in this field should read it, published in Neuromodulation 2017, PAC, Polyanalytic Consensus Conference. Just to keep it short, if we have patients with tumor pain, we should start with the intrathecal therapy, with the pump therapy. If we have patients with non-tumor pain, then we should start with leads, with spinal cord stimulation, peripheral nerve field stimulation, and if these therapies don't help, only then move on to the intrathecal therapy. A provocative question, are we going to jail? Why? Actually, the only FDA-approved drugs for the pumps are morphine, ziconotide, a non-opioid, and baclofen. Not a combination of them and no other drugs. In everyday life, we are using mixtures of these drugs and mixtures of many other drugs, local anesthetics as well, sufentanil, hydromorphone, and many, many other drugs. But actually, all of these things are off-label. And this is why in 2019, the colleagues, the big names in this field in the United States, published this article in order to raise awareness about this problem. We should not forget ziconotide in the intrathecal therapy. If you are interested, this is a review article published in Brain and Behavior from many colleagues from many European countries. This comes actually from a cone snail. It's a peptide, acts at the dorsal horn, and actually it blocks the calcium channels. This is the way it works. If we have patients now with cancer pain, we don't have any maximum dose with this drug. If we have patients with non-cancer pain, then the experts are saying that we should try to give this drug till a maximum dose of 19 micrograms per day, not milligrams, micrograms per day. And if that doesn't help, then we should not try to increase the dose. It won't help. What's really important here is that one should start with a very low dose of 0.5 or 0.6 micrograms per day, once again, micrograms per day, and do the titration really, really slowly. The problem that we had with this drug in 2005 in Europe and 2004 in the United States was that the colleagues back then started with a very high dose of 2.4 micrograms. So actually, 4 times more drug than now. And they kept increasing the dose every 1 or 2 days. It was too fast. Patients had problems. What types of problems? Psychiatric problems. This is why one should be careful with this drug. And if we follow these suggestions of the experts, I think the problems are much, much less. For this therapy, we should implant a catheter in the intrathecal space, and we should implant a pump in the abdomen. This is why the patient should lie on this way on the operating table, so that we have access at the same time to the lumbar spine and to the abdomen. Usually, we implant the pump on the right side of the abdomen, on the left side of the abdomen, sorry. Why? Because on the right side, we have the liver, and sometimes the pump could exert some pressure on the liver. But there are some patients who explicitly want to have the pump on the right side. This is also possible without any big problems. The needle insertion, we should have an angle of 30 degrees if it's possible in order not to injure any neural structures. Where should we go in the epidural space? This depends from the colleagues. Let's say somewhere between L2 and L4. The next question, where should we place the tip of the catheter? It depends on the clinical problem. It depends if we have pain as the main indication or spasticity on the main indication. It depends on the drug. We have hydrophilic drugs. We have lipophilic drugs. But as a rule of thumb, I would say maximum a T4, in the majority of the cases a T8 under fluoroscopy. And this is what we see in the operating room. This is the gold standard in pumps. This is not an advertisement for the specific company or the specific pump, but at least in Europe, we don't have any alternatives. This is the synchron pump from Medtronic. You can see here there is a black needle in order to do a puncture in the port in the middle of the pump. This is how we refill the pump. And we have also a violet needle. This is in order to make a puncture in the side port on the right side of the picture. Why would we like to do that? In order to aspirate cerebrospinal fluid, CSF, or if we would like to give as a bolus a specific amount of drug. This is what we see also in the operating room. You see the pump in the pump pocket. The instruments we are using, actually, we don't need so many instruments. It's a pretty simple surgery. And this is something I'm showing to you because it could lead to problems. After the implantation of the catheter, we should have an X-ray. But the main catheter of Medtronic, Ascenda is the name, has the following problem. We can see only the tip of it, this small white point. And if we don't know it, and if the radiologists don't know about it, then they will probably say that they cannot see any catheter. Okay, so if we know that this is a specific catheter that we planted, we should always look for this small white dot. Not visible in all patients. Okay. Some time ago, or 20 or 30 years ago, we had such pumps. These are gas pumps. There was no battery there. There was a gas, butane, in the majority of them. And each day, these pumps could deliver a specific volume of drug. So we have the programmable pumps with batteries, Synchromed from Medtronic, Prometra in the United States, not in Europe. And Tricomed is a company, a German company, produces gas pumps, not programmable pumps. There are some advantages, there are some disadvantages. The programmable pumps, we should replace them every 6 to 7 years because the battery is empty. But we can very easily change the dose of the drug. The gas pumps, the non-programmable pumps, have a life expectancy, let's say, of more than 15 or 20 years. But each time we have to change the dose, we have to empty the pump and give a new concentration of the drug. This is a gas pump in the operating room and the corresponding X-ray of this pump. You see also these pumps have two ports, one almost in the middle in order to refill it, and one port laterally in the nose of this pump in order to aspirate cerebrospinal fluid. This is how Synchromed 2 looks like if we open it up. The biggest part of it is, of course, the battery and the corresponding X-ray of this pump. And this is the main advantage of Synchromed or of the programmable pumps. We can have different or various infusion modes. We can give a drug continuously, or we can program different volume of the drug. This is particularly useful for patients who say who have mainly pain or more pain at night, or in patients with spasticity who say we have more spasticity at night. Then we can program the pump in such a way so the patient gets more drug during the night. Once again, all these therapies are not new. This is a publication come from 1978. I was born in 1977, so I was 1 year old when this publication came out. It's about the use of baclofen against pain, not against spasticity, against pain in animals. And the authors here, and Yax is a big name, was a big name in the field, actually showed that it can help for pain. What about in humans now? In humans who do not have spasticity, can we give baclofen? Yes, and also helps for pain. This is also a publication coming from 2000, not a new publication. What about in humans with spasticity? If we give it baclofen, baclofen improves spasticity, but at the same time can suppress this aesthetic pain. Publication coming from 1992, not a new publication. And now, what about baclofen and quality of life and pain in patients after stroke? Many patients after stroke have spasticity, and many patients after stroke have also pain. So this very interesting publication was published in 2018 in Stroke, a very good journal. And actually, the colleagues here showed that the pain in these post-stroke patients was much better if we administered baclofen intrathecally. And what about the combination of baclofen and morphine intrathecally? One publication from 2012 here. It is possible to combine. The clinical effects are really good, but once again, it is an off-label use. It's not FDA approved. We have proven, however, that the stability of the drugs in the pump of baclofen and morphine is pretty good. So actually, there shouldn't be any problems. The drugs are still stable, at least 30 days after the filling of the pump. And what about the cost? Because this is the question we are getting every day from the insurance companies. There are publications, one of them from 2015 in neuromodulation, showing that we have a reduction of cost if we implant pumps. Why? Because the patients do not need so many drugs anymore. They are not coming so frequently to the hospital or to the emergency department. So we can save money as a society. And coming to the end of this part of the presentation, at the level of third neuro, we have motor cortex stimulation and deep brain stimulation. These are too complicated. I would just like to show some photos here. This is the implantation of a lead for stimulating the motor cortex. Main indication is a neuropathic pain in the face, permanent burning pain in the face, or thalamic pain, mainly in patients after stroke. In my department, we don't offer this therapy very frequently because we saw that the infection rates are pretty high, and because we have seen that after some months, the patients are coming back with loss of efficacy. So the pain is becoming more and more in the next months. Although I must say, other colleagues from other centers have a different experience. And as last resort therapy, we have deep brain stimulation, DBS, implantation of leads in our brain for patients with neuropathic pain, with fundal pain or trigeminal pain. It is not in any guideline. Okay, this therapy, it's pretty experimental, and we do have big problems with the insurance companies. But as I said, it is a last resort therapy for patients who tried everything else and they still have severe pain. This is a therapeutic algorithm, an old one. When the patients came to us with pain, we asked them, is it local, is it radicular, is it polyradicular, is it multifocal? So if it was not multifocal, we tried with pulse radiofrequency, then with subcutaneous leads if it was local, or spinal cord stimulation with 1 or 2 leads. And if the patients were not satisfied with all these therapies, then we moved on to the intrathecal therapy, to the pump therapy. If the patients, after trying different drugs, were not satisfied or they had adverse effects, problems with the drugs, then we tried motor cortex stimulation or deep brain stimulation. And in the end, we have the ablative therapies, the destructive therapies. Okay, this is an old algorithm. Why? Because with all new waveforms that we have in spinal cord stimulation therapy, the clinical results are much, much better now. They are so good that in the majority of cases, we don't need the pulse radiofrequency therapy or the peripheral nerve field stimulation therapy, or not even a pump. In my department, we plant much less pumps now because the clinical results with spinal cord stimulation are much, much better. And this one more neuromodulation option, sphenopalatine ganglion stimulation. Here one should implant a microstimulator in the sphenopalatine fossa. The only indication was cluster headache. And each time the patient was feeling that an attack was coming, should hold this black device over the skin, over this microstimulator, and clinical results were pretty good. At this point, we don't have a CE mark for this implant, meaning we're not allowed to offer this therapy. We are waiting for the official CE mark once again. But the therapy was pretty effective. Okay, we have many therapies, we have algorithms. What we should never forget is that every patient is different, and almost always the simplest solution is the best one. And the simplest solution is a solution or a surgery without many foreign materials, without many leads. It is possible to help many patients with chronic pain and spasticity, not all of them. And when we are saying helping them, we are not meaning that they are going to be pain-free, but they are going to have a substantial pain relief. And in combination with physiotherapy, psychological therapy, and some oral medications, they can have a pretty good quality of life. Hopefully you're still with me and it's not really boring. And the last part, a short one, but just I want to give you an insight in this social media world. For example, on Facebook, there are many support groups for many diseases, for back pain, also for spinal cord stimulation therapy. And these are the most common topics of interest. This is what patients are talking about on Facebook. So I read many posts and I summarized the findings here. Most of them are visiting the support groups and they are asking for information before the implantation of a system or before the explantation of a system. They are asking about the indications, about the physicians who are performing such surgeries, and about the companies who are providing the implants. About problems such as infections, bleedings, hematomas, pocket pain, pain in the area of the battery, eventually paralysis, overstimulation, MRI possibility or not. In the United States, many patients are asking questions about legal issues, lawsuits against companies or insurance companies. This is something we don't see in Europe. And there are many questions about the company representatives or reps, about the reprogramming, if they were good at reprogramming the system, or if they were available when they needed a new programming of the system. Chronic pain patients are not simple patients, they are complicated patients. And this is a very interesting publication, Neuromodulation, on spinal cord stimulation and support groups. Here the authors gave some examples. I chose one of them. Look, please, on the left side on the screen, what a patient said. I joined a group on Facebook. You see the ones that these photographs on and their back, they are just a mess. There was one lady, hers was in her stomach, and it was sticking right out, and I thought I couldn't study it. You could see the whole shape of the square, and she was having to go back, and I thought just, I don't know if I can put with that. So imagine you have a patient who could be a good candidate for spinal cord stimulation therapy, and this patient visits a Facebook support group and reads something like that. I don't think he could be too excited to come to the hospital to have this therapy. This is why we should not underestimate the power of social media. And in my opinion, we should try at least to be a little bit active as physicians on the social media in order to try to inform patients better, in order for them to be able to get some good decision based on objective information. What we don't need is this mentality that the patients are belonging to a specific physician, to an orthopedic surgeon, to a neurosurgeon, to a pain physician. It's not one man show, it's a teamwork. We have all to work together. Once again, if the patient has a spinal cord stimulation therapy or an interthecal therapy, that does not mean that the patient does not need a pain physician or psychological therapy or a physiotherapy. All these therapies are working together. This is why we need teamwork among all colleagues. And to sum it up, pain is really undertreated, has a really high economic burden. All these neuromodulation options can improve the quality of life, and if we apply them with the right indications, can reduce the hospital costs. Of course, we need individual therapy concepts. Of course, we need a multidisciplinary pain medicine. And of course, we need to respect the autonomy of our patients. If you are interested in neuromodulation, please visit the social media accounts of the Journal of Neuromodulation, Facebook, Twitter, and Instagram. If you have any questions, I will be glad to answer them. If not now, just send me an email. This is my email address. I would be happy to get back to you. Once again, thanks for listening to me. Thank you for the invitation. And Neurosurgical TV, thanks for organizing it.
Okay, Giorgio, thank you very much. Comprehensive broadcast. Now, Abdul, are you there? Abdul, you can kind of moderate if you'd like. Are you there, Abdul?
Yes, I'm here.
Yeah, okay. Could you, do you want to moderate the questions? Or I can do it, whatever.
Yeah. Please, if you have any question, you can send it through chat, yeah?
Yeah, I'm an aggressive questioner, Giorgio's. I've learned to be more aggressive. Now, Ahmad from Afghanistan, he's the head of neurosurgery in Afghanistan. Are you there, Ahmad? Can you comment,
Hello.
please?
Hello, Assalamu alaikum. Hello.
Hello.
Professor John. Hello. Thank you very much.
I'm not a professor, just a senior consultant.
Thank you. Thank you very much.
You're welcome.
Gracias.
Okay, very good. And Ravshan, the head of neurosurgery, you can introduce yourself, Ravshan. It's nice to have you. Do you have any comments or questions for Giorgios? He may have stepped away. Sometimes people are in the hospital. And well, I have a few questions. As you know, Giorgio, addiction is a big problem in America with OxyContin. The OxyContin, you have that drug over there, I'm sure, right?
It's not that big in Europe. It starts now becoming important, but till now we didn't actually have this problem.
Yeah, it was a very abused drug, unfortunately, in America until they put really tight controls on it. But I know a lot of these patients, they don't want to be addicted. They just want the pain to go away. They'll do anything. Now, you already kind of answered. There's not a big problem right now, addiction with pain medicine over in Europe, in your experience? No?
No.
Okay.
But this, of course, depends on its country. I cannot say that's the same in all countries. For example, in the Netherlands, I think the problem is a bit bigger than here in Germany. But if you compare the countries, Europe and United States, the difference is huge. The problem is much bigger.
Yeah, it's much more serious.
And this is why, for me, it's a surprise that in the United States, neuromodulation options are not so famous. Actually,
really, it's harder to get
a good opportunity for this therapy to become more well-known.
Okay, so it's kind of slow in countries like America as far as new technology, because obviously it has to be approved by the FDA.
I don't have any experience. I have never worked in the United States.
Oh, okay.
How the system is working, but I would expect especially after all these publications about addiction and deaths in the United States, that neuromodulation options and mainly spinal cord stimulation would be in the forefront because there are a reliable alternative and they are reversible. All these options are reversible.
Now, in your experience, pain modulation, pain control is kind of like an understudied subspecialty of neurosurgery, because during a residency, is a resident required to like take a month somewhere on pain management, or that's just an option for, it's not in the normal curriculum of a neurosurgery training.
This is why I told you before, in the medical school, we almost never hear anything about neuromodulation or surgical treatment of chronic pain, or even about pain in total. We don't hear anything. As a residents, it's not part of our curriculum to learn such surgeries, or it's a really, really small part. This is why it's a great joy for me to be able to participate in such webinars and just speak a little bit about these therapies, with the hope that there are going to be colleagues out there who will hear about these therapies and get interested in these therapies, learn these therapies, and offer these therapies to their patients in all countries all over the world.
Well, you certainly are well known. I see it on the internet everywhere. So you're certainly making an effort to spread education. And we mentioned this before the program started. But yeah, neurosurgeons only have so much time. And obviously, if they go to a webinar, it's going to be to a trauma or something big. And we're saying how Zoom makes it much easier for a resident to attend. And they get credit too in some of the webinars for attending, say, pain management or whatever.
This could be an issue, but please don't forget, in the majority of the countries, it is the anesthesiologists who are taking care of patients with chronic pain, not
okay. Oh, I see.
Germany
I see.
is a huge exception. In Germany, for the surgical treatment of pain, there are only neurosurgeons here in Germany who are doing this. In the Netherlands, Belgium is completely different. It's almost only anesthesiologists who are taking care of these patients with chronic pain surgically. This is also a difference.
So you do get a following of anesthesiologists, and there's more interest in anesthesiologists in pain management. There's more
worldwide, yes.
Worldwide,
and the
but not in Germany. In Germany.
In Germany, we have the anesthesiologists who are offering the conservative treatment of chronic pain, so medications only. And then we have neurosurgeons or orthopedic surgeons who are taking care of the surgical treatment of the chronic pain.
Wow, orthopedic surgeons, I haven't heard of that.
In the United States, it's completely different. They are both anesthesiologists and neurosurgeons, but at the same time are taking care of the medical management of the pain and the surgical management of the pain. So this is why you cannot generalize what we are saying. It depends on each country.
Yeah. Again, it's like peripheral nerve injuries. There's not much formal training during residency, but the internet's opened an avenue, open a possibility. Okay, any more comments or questions, or someone that just wants to meet Georgios? Oh, Ahmad, go ahead, Ahmad.
Yes, thank you very much, Professor John, Professor Georgios. It was really excellent presentation, and we learned a lot, but unfortunately in Afghanistan we haven't any possibility for neuromodulation, and I saw this the pain management and DBS and morphine pump and baclofen pump and Germany and also in the United States, but in Afghanistan, unfortunately, we haven't the possibility to put the pump for pain relief, but we use the classic sometimes for neuralgia, but alcohol and
Glycerol.
lidocaine, yes, and for chronic back pain, we use the steroid and some anesthetics do, but we do it by a neurosurgeon in Afghanistan, and but we hope someday we it's be possible to do in Afghanistan as well, and we like to have your guidance, and also if it's possible for train young Afghan neurosurgeon as well.
Well, would be nice to do something like that. But this is a valid point because all of these surgeries who are associated with implants are really expensive.
Yes.
There are not so many countries which can afford this. This is the truth. This is why we're trying to speak with the big medical device companies and trying to find a way, at least in some countries, to try to reduce the cost so that it would be possible at least to do some implantations there. This is a huge problem, and you are right.
Yes. Thank you.
Yeah. Yeah, and the first step is education, right?
Yes.
So that they know these options are available. In the United States, to get a device approved, you have to go through various stages. I'm sure it's the same. It's called a CES, right? In Europe, the agency that approves new therapies. Is that what the agency's called?
I don't know which is the name of the agency, but we have in Europe an agency which is responsible for all medical products.
Right.
This is why we are getting this CE, this European mark.
The CE. Okay, that's what it's called.
The procedure now has become really complicated and takes too much time. Some years ago, it was much easier to launch a product here in Europe and not in the United States. And this is the reason why we did in Europe many publications many years before our American colleagues did that, because they didn't have access to the products back then.
Right.
Now it's easier in the United States to get the approval of FDA than here in Europe. And this is why now you see all new products are tested in the United States, and after some years they're coming, or some months they're coming to Europe.
I thought it was the opposite. I thought it was the opposite. It was easier.
It was the opposite 1 or 2 years ago. Now we have a paradigm change.
Oh my God, the United States is doing something better than someone else. I don't believe it.
There are some good things in the United States as well.
Yeah, there are other things. But I love this country. But Georgios, product approval and working, it must take a lot of patience. A lot of patience to kind of, if you know something works and you just want to use it.
It's exactly the same as the intrathecal therapy with a combination or a mixture of drugs. We know that it works, we know that it's safe, but it's not FDA approved.
Okay. Very good. Excuse me. Hold on. I'm sorry, Georgios. Okay. More comments or questions? Or anyone that just wants to say hi to Georgios?
Thanks for joining us. Once again, I'm always available for questions. Just send me an email. I will get back to you.
Yeah. Sometimes people are a little shy and certainly you got his email. Could you put your email up there again, Georgios? So
1 moment,
just
please.
to remind people, you're always welcome to.
Here you are.
Okay, everyone's got that.
But did you drop the call or did I drop it?
Excuse me, my brother's calling.
Family comes first.
I'm sorry, I tried to get him out. Okay, well, one thing I want to talk to you about. Hey, we got that. Let me stop the share. Okay. Yeah, Georgios, one thing we could put in mind is maybe have a small conference on pain modulation online, possibly. And the people that help do that are companies that make these devices. For example, I'd be perfectly willing to broadcast from a company, basically, just the way in the world, essentially, pharmaceutical companies and drug device companies, they sponsor conferences. And the same thing can be done online. If you have
it's not cheaper.
Right, if you have a company you work with, well, I'll talk to you after that. I'll talk to you after the
Well, in
podcast.
Cologne, we're working with all companies. We're really democratic.
Oh, okay. Well, we'll talk about this later. But let's see, Mauro, are you there? See, I don't know if Mauro is from Mexico. He's here. There's a couple of people. Let me ask him if he's in. He's someone I know that just joined. Mauro, are you there? He just came in here. Let's see. Let me see if Rob Shan, have you stepped away? Are you still here, Rob Shan? And Omar is still there. Well, that's okay. Okay, Georgios, thank you very much, and hang around just a sec. Okay, we're going to end this formally. We're going to end this formally. Thank you very much, everybody.
Okay, I would like to thank Dr. Georges for giving us the webinar.
Thank you very much for inviting me.
Yeah, thank you so much for accepting our invitation.
Okay, Abdul, thanks for getting it together, and we'll talk to you soon. I'm going to end this formally. Okay.